afternoon, everyone. I'd like to welcome you all back to Riverside Talk, our health webinar series. Today, let me just start by introducing myself. I haven't done this in a few months, so now I have to get back in the swing of things. I'm Denise Mananis. I'm the Assistant Vice President for External Affairs for St. John's Riverside Hospital. And before we begin, I'd like to acknowledge my team. Jason Latore, who's our media production manager, Nancy Anabi, our community liaison, and Candace Cousins-Hopkins, our associate director of external affairs, all of whom do all of the hard work in putting these programs together and making them really wonderful educational series for our community. I'd also like to acknowledge our original partners. That is Yonkers Neighborhood Naturally Occurring Retirement Community, and the Yonkers Public Library, who helps us spread the word and have their members join us and watch our programs. Our new partners today, Ashling Irish Community and Cultural Center, the Department of Veterans Services for the City of Yonkers, Ardsley Parks and Recreation, Ardsley Senior Center, Bronxville Community Center, the City of Yonkers, the Community Baptist Church, Hastings Community Center, Irvington Community Center, Westchester Jewish Community Services, and Yonkers Pathways to Success. These are all organizations that joined us earlier this year and also are helping us spread the word and getting these webinars out to their communities. And if you are part of an organization locally and you would like to join us in sponsoring these, please email us at info@riversidehealth.org. For our audience, by the way, if you have questions during the course of the webinar, please put your questions into the chat, and at the end, I will look and see if there are questions that have not been answered during the course of the program, and we will get those answered for you at that time. So now, without further delay, I'd like to welcome Dr. Mathew Fakhoury and thank him for being with us today, and I'd like to tell you a little bit about him. Dr. Mathew Fakhoury is a urologist with Advanced Urology Centers of New York. He completed his Doctor of Osteopathic Medicine degree at New York College of Osteopathic Medicine and a urological surgical residency at Cook County Health and Hospital System in Chicago, Illinois. In 2020, he won the LUGPA Resident Clinical Innovation Award and has published extensively in the urologic literature. He is a member of the AUA, Sexual Medicine Society of North America, the Society of Urologic Prosthetic Surgeons. He specializes in urinary dysfunction, benign prostatic hyperplasia, kidney stones, and sexual dysfunction. So with that, Dr. Fakhoury, thank you so much for joining us, and welcome.
Thank you. Thank you for the wonderful introduction, and I'd like to thank the rest of the committee and all the team members in putting this together.
Thank you.
Once we get the webinar up and rolling, what a lot of our viewers don't realize is how often we speak to each other and try to coordinate these kinds of events in order to spread knowledge and help the community. So I thank you all, and I thank the partners as well.
Thank you for that. My team is a hardworking group for sure.
Absolutely.
So let's start with some basics, right? At what age, because we're going to talk a little bit about the benign prostate situation as well as prostate cancer. So, but at what age should men start checking their prostates, and then how often should that occur?
So, generally speaking, we talk about the age of 50 years old. Now, 50 years old is more of a ballpark age where we begin to discuss with our patients, usually starting at the primary care physician's office, regarding prostate cancer screening and whether or not patients have any difficulty in emptying their bladders. Now, 50 is more of a general age. However, there are things that we discuss with patients that include race and whether or not there's a family history of any malignancies. And if there is either of those things, African American men are actually at a higher risk of developing prostate cancer, more aggressive prostate cancer at an earlier age. So when we discuss the points of prostate cancer screening, we have to keep in mind that there are other factors such as age, other than age, such as ethnicity malignancies, whether it might be breast cancer or prostate cancer in the first degree relatives. So with that in mind, we usually start around 45 years old. So about 5 years younger, we'll begin the prostate cancer screening. And this is kind of the perfect time to discuss this, given that it is Movember, Men's Health Month overall. So I think this is perfect timing to kind of bring the attention to the male community, as well as their counterparts, their partners, and how important it is to make sure that we discuss this with our primary care physicians.
So in other kinds of cancers, the testing is, you have a baseline and then maybe you skip a few years. Is that the recommendation for these tests for prostate?
So per the American Urologic Association guidelines, if we were to start the PSA or the prostate cancer screening at the age of 50 years old, it's typically done once a year and not much more than that, unless there's any concern that there's an elevation in the prostate specific antigen level. And the number that we're looking for is generally 4 or below. Now, I don't want to get into the weeds, but it depends on really the age of the patient, the malignant history, the family cancers, and whether or not the patient's of African American descent, that we discuss maybe doing this a bit sooner, depending on what that PSA level is.
All right, so what I'm hearing you say is it's important to go to the doctor and you have to go every year.
It is important to go
and have the discussion. Okay, so let's go back to the screening tests that are available for prostate cancer. And then, so the tests, and then what are the associated risks with the tests, if any?
So there's really 3 things that can happen to the prostate, and I call the prostate a troublemaker after the age of 50 years old, because it does nothing but cause trouble for most male patients. BPH is one thing. We're talking about prostate cancer, of course, and then prostatitis. So we'll kind of break down things in that sort of trifecta, the 3 things that are possible to happen to the prostate. When we talk about prostate cancer screening, the most common form is with a blood test called a PSA, or prostate-specific antigen. And that is just a simple blood test that it doesn't have to happen at the urology office. It can happen at the primary care physician's or any physician's office for that matter. We break down the PSA into free PSA and total PSA. There are other tools out there that we have in our armamentarium other than just a flat PSA, because although it is sensitive, it is also not very specific. And what I mean by that is you may have a PSA that's considered elevated per the guidelines. However, it could be elevated because of having an enlarged prostate or having an infection in the urine. So there's 3 different things that can elevate the PSA in a man. And this is exactly how I have my discussion with my patients. It's having a large prostate, because if you have more prostate, you will make more PSA. Makes sense. Second point is whether or not there's an infection in the urine, because anything that can cause inflammation in the prostate gland will cause the PSA to rise. And the third point is whether or not prostate cancer is involved. Okay, so there's 3 reasons why the PSA might be elevated. Now, because the PSA blood test is sensitive but not so specific, there are other things that we can utilize, such as urine tests. I believe our office is one of the few offices in Westchester County offering ExoDX, which is basically a simple urine test. And the urine test allows us to figure out what is the risk of developing high-risk prostate cancer in the next 10 years. Okay. Now, moving on from screening tests, if we have a sense of an elevated PSA and there's no infection, okay, we talk about biopsy of the prostate or an MRI of the prostate. It depends. It's urologist specific whether or not patients get an MRI first or prostate biopsy first. The MRI is kind of a cutting edge way of us getting a really good blueprint of the prostate gland, its dimensions, and whether or not there are any lesions in the prostate gland that are concerning for prostate cancer.
That's very interesting. And so when you say urologic specific, you're talking about the doctor choice. Absolutely. As to whether or not they feel that it's necessary.
And just to throw that a quick one-liner in about MRIs, MRIs are read by the radiologist. So you want the MRI to be read by a radiologist who is comfortable reading these prostate MRIs, because one lesion may look suspicious to one radiologist and it may not be suspicious to another radiologist. So I would keep that in mind.
Okay. And to go back to the risks associated, so a blood test, MRI, there are really no risks, but the prostate biopsy, that's a little bit more invasive, yes?
Exactly right. It is more invasive. So with a prostate biopsy, there are certain criteria that we have to ensure that our patients get when they get a biopsy. They go on pre-procedural antibiotics. They're given an enema the night before, an enema the morning of. They're given antibiotics in our office, and they go home with antibiotics. Why? Because we want to reduce the risk of infection as much as possible. So sepsis associated with biopsy is one of the things that we concern ourselves with, and we take every precaution necessary to make sure that doesn't happen. There are other associated risks with a biopsy, such as bleeding in the urine, semen, and in your bowel movements. These usually last up to 3 days. Sometimes my patients don't even have the bleeding, but sometimes they do, given that some of these patients are on anticoagulations and maybe taking aspirin or Plavix or whatever it may be. So there's an increased risk of bleeding, but it's usually more along the lines of spotting.
Okay. All right. So let's take one of the topics now and just talk about the risk factors for prostate cancer.
Yes. So risk factors. Age is number one, of course. Okay. We know that as men increase in age, there's a higher risk of developing prostate cancer. Race is another point. Okay. As we said, African-American men are at an increased risk of developing prostate cancer. Family history of whether or not patients have had relatives with prostate cancer and first-degree relatives, and if there's any genetic mutations that are known within the bloodline of the patient, because some of the genes that are responsible for causing prostate cancer also cause breast cancer, for instance. So those are some of the things that we discuss about when we discuss risk factors for prostate cancer development.
So that's very interesting, and I think I've asked this question in a different webinar from the reverse side. I think it was in the breast cancer webinar, but there is a relationship. So if you're a man whose father did not have prostate cancer, but your mother had breast cancer, then you still need to look at that as a hereditary issue.
100%, because one of the gene mutations that causes breast cancer is BRCA, BRCA, and that's also responsible for developing prostate cancer cells in patients. So there is absolutely a connection between the two.
Okay. Now, is it possible that this develops without any of those risk factors, that you can get it because just organically, you're the unlucky one?
Unfortunately. Now, when we talk about prostate cancer, for the most part, is a disease that is silent, and many men may have prostate cancer in their 80s and they don't even know that it's there. So we're very good at treating and controlling prostate cancer in patients where it's caught early. So there may not be signs and symptoms of prostate cancer up front. Okay, so it's important to keep in mind, well, my patients tell me, I have a guy who comes in with a PSA of 7, 8, or 10, but doc, I feel fine. I have no issues whatsoever. Unfortunately, that's just not enough for us to ignore and say, okay, as long as you feel fine, I'm not too concerned about it, because it can sometimes be silent.
So in terms of signs and symptoms, it's really, it could be very quiet. You're really not even aware that there's any impact to you. And so again, it goes back to the idea that you have to go to the doctor every year and have the test and sort of stay on top of it in order to catch anything early. Is that a fair statement? That's
very well said.
Okay. So, all right, what now, having been through this in my life with some members of my family, but that's quite a long time ago, how is prostate cancer treated now? And one of the things that I would like you to discuss is the fact that at St. John's, we actually have a new treatment here for prostate cancer called Focal One. But first, walk us through the treatment for prostate cancer.
Absolutely. So in 2023, there's an expected rate of about 300,000 men in the United States who will be diagnosed with prostate cancer. Of those 300,000 men, we're expecting the number of deaths to be from 35 to 40,000. That's not insignificant. So after skin cancer, prostate cancer is the most common cancer diagnosed in men. How do we treat prostate cancer? So when we discuss treatment of prostate cancer, we typically break down prostate cancer into 3 categories. We're going to take something very complex such as cancer, and we're going to break it down as simply as possible. Prostate cancer is either low risk, intermediate risk, or high risk. When we talk about low risk cancer, this is something that can be typically treated with active surveillance. Active surveillance basically means that, yes, there is, Mr. Smith, there is prostate cancer inside of your prostate, but the chances of this prostate cancer becoming something that will affect your life here on God's green earth is very unlikely. So what we're going to do is watch this very closely. How do we do that? We get a PSA every 3 to 4 months and make sure that the PSA doesn't jump up. And then that'll be a trigger for us to actually give some type of therapy. When we talk about intermediate risk and high risk prostate cancer, we begin to discuss the options such as surgical removal of the prostate gland. Typically that's done with a robot. Or we talk about radiation therapy. Radiation therapy is when you want to tailor the therapies towards the male patient. If erections are very important to a patient, okay, and the idea of them not being able to have an erection on demand like they normally would, then surgery is probably not the best option for that patient. Okay, we begin to talk about radiation. Radiation therapy is offered in one of our centers for advanced urology here in the Westchester County area, and essentially what we're doing is basically giving radiation to the prostate gland and the bed surrounding the prostate gland, and that's typically done on a daily basis for about 4 weeks, 5 days a week. But it is not invasive.
So just let me ask you a quick question about the radiation. So the radiation is an external beam, and was there not a time where they did seed implants for radiation? And is that something that still exists?
It is something that still exists. It's called brachytherapy or seed implantation, which delivers radioactive signals within the prostate gland instead of getting radiation signals from outside of the body. So it's definitely something that is out there on the market for sure. When we talk about hormone therapy, we discuss whether or not, if a patient has high-risk cancer, we talk about hormone therapy, where we basically have to shut down the production of testosterone, which is basically the fuel to the fire for prostate cancer. And that's typically given through an injection or pills by mouth. But that is reserved for the high-risk prostate cancer patients, or the prostate cancer that's been diagnosed as metastatic disease, meaning it's no longer just within the prostate gland and it's in fact outside of the prostate gland. But you mentioned something earlier, and I'm really, really happy to say that we're basically the only hospital in the region to deliver Focal One therapy. Now, Focal One is the first and only robotic platform where we can use focal ablation of the prostate tissue using high-intensity focused ultrasound waves, and that's delivered by the urologist. Right now, St. John's is the only place in the region where we can offer this to our patients, and it's basically the first and only robotic platform out there for treating prostate cancers.
So this is not an invasive procedure, right? This is a minimally invasive. Explain what that is.
I would absolutely consider it a minimally invasive procedure in that the patient comes to the hospital, is put asleep with anesthesia, a probe is introduced into the patient's bottom through the rectum, and that's as invasive as it gets. It is not any more invasive than that. There are no cuts or incisions with this procedure.
So the ultrasound waves is what is used to treat the whatever lesion is on the prostate.
Now, what's important to note about Focal One is its specificity, meaning sort of the way a sniper would target his target. Basically, we're able to accomplish the same thing when we see that there's a lesion that's concerning for prostate cancer or diagnosed with prostate cancer. We can pinpoint and target that lesion.
Okay. Well, that's great, and we're very excited to be able to have that therapy here. So, but let's move on and let's talk about some of the other parts of the prostate world, which let's talk about the enlarged prostate, otherwise known as the benign prostatic hyperplasia. And so, are the tests the same? What are the signs and symptoms of that for men?
So So now that we've sort of covered the prostate cancer portion of things, a lot of the reasons why urologists will see a patient in their office is because of trouble with the plumbing system, essentially. And one of the things that we discuss with our patients, what kind of symptoms, would be waking up more often than they would normally like to wake up, meaning they're not getting a good night's sleep. That's called nocturia, where a patient has the urge to go to the bathroom while sleeping and has to make his way over to the restroom. Dribbling of urination, sort of like a slow faucet, meaning when a male is completed with his urination and he still feels like there's a trickle and he has to wait in front of the toilet more than usual, that's a sign and symptom of having an enlarged prostate. When the flow becomes weaker or slower and patients feel as though they're having to use their straining muscles or straining their core to get the urine out, that is also a telltale sign that there's some type of prostate enlargement or obstruction going on. So the issue with prostate enlargement isn't really that it's enlarging on the outer surface. It's really that the inner channel inside of the prostate gland is becoming thinner and thinner. And as a result of that, instead of a patient being able to pee out of a pipe that's this wide, we're dealing with something like that. So that's essentially what benign prostatic hyperplasia causes. It's a blockage of the urinary flow from the bladder to the outside of the body.
Because the prostate is getting enlarged.
Because
so it's pressing on the bladder.
Exactly. It's pressing on the urethra.
On the urethra, which is the tube
of urine into the bladder. Exactly.
Okay.
Testing.
And so what do you do for testing for that?
So testing. Different ways to test for benign prostatic hyperplasia or incomplete emptying of the bladder as a result of a bladder outlet obstruction. Okay, now BPH does not cause prostate cancer. However, the symptoms may coincide with that. Okay, with respect to testing for benign prostatic hyperplasia, your urologist will talk to you about a post-void residual, which is basically where a patient urinates into the toilet, and we measure how much urine is left over. Okay, that's called residual volume. We measure how much urine is left over in the bladder. Our office currently is the only office providing a urocuff, which is basically a non-invasive way of measuring the volumes and pressure relationships of the bladder and the prostate. So a urocuff is something else a urologist may talk to you about. A uroflow, which is basically us measuring how fast the urine is coming out of the bladder. And a cystoscopy, which is basically a small camera. It takes about 30 seconds to complete. Camera goes into the penis, and we're able to look at a screen with our patients and kind of point out where the obstruction of the prostate gland is. And it also gives us an idea of how healthy the bladder is as a result of it pushing and squeezing the urine out. So none of these tests are really invasive other than the cystoscopy, and that's about a 30-second test that we do in our office under local anesthesia.
Okay. So does family history play a role in developing BPH?
It does. It does. A lot of patients will come in and say, you know what, I remember my dad having to wake up quite a few times in the restroom, and I feel like I have to go through that now. So there is a genetic component associated with benign prostatic hyperplasia. Is
this just a normal part of aging for men?
Great question. Yep, that's exactly right. After the age of 50 years old, 50% of men will experience benign prostatic hyperplasia symptoms. 60% of men in their 60s and 70% of men in their 70s. It's almost inevitable. It really just depends on how frustrated the patient becomes, because this is more of a quality of life issue. If patients feel like they're waking up more often at night and not getting a good night's sleep, they wake up tired, they're standing in front of the toilet more often and for a longer time, these things will bother a man and change his quality of life, which is basically at the point where they'll come and see a urologist and say, I need this fixed.
And so great intro there. Great segue. How do you fix it?
How do we fix it? So we've come a really long way with developing some cutting edge tools in order to reduce prostate volume. Now, the first thing I discuss with my patients is bladder training. Okay, I call it the rule of twos. It's really 3 simple steps, and this is both for men and women, believe it or not. But given that we're talking about the prostate, when it comes to men, the 3 simple rules are the following. going to the bathroom every 2 to 3 hours, and try not to hold your urine for longer than that. Even if you have no sensation to go, you should still get in the habit of trying to use the bathroom throughout the day and not go more than 4 hours without voiding, because once BPH is in the picture, your bladder is no longer functioning appropriately, and it's not sending signals to your brain that you have to go pee, so it becomes adapted to having large amounts of urine in there without you feeling it. The second point is going to the bathroom twice. What do I mean by that? You go to the bathroom, you pee, you feel like you've completely emptied your bladder. You're going to take a 10-second pause and basically move your feet up and down and pee again. That's called double voiding. It allows us to get rid of the residual urine sitting in the bladder at the end of our urination. The third point is 2 hours before bed, minimize fluid intake. Okay, now a lot of our patients have to take medications at night, so we tell them, have a sip of water, that's no problem. But if you're at a point where you're experiencing waking up at night, you're definitely going to worsen that by drinking before bedtime. So the first part is bladder training, behavioral modifications, the rule of twos, as I briefly discussed. The next option is medications. Okay, there are certain medications out there that we know work well in opening the prostate gland and opening the bladder neck. Some of our viewers may be familiar with tamsulosin or Flomax or alphazocin or finasteride. Finasteride is a medication meant to shrink the prostate gland, and tamsulosin opens it. Okay, I refer to it sometimes as the human Drano. It allows the plumbing system to empty out the urine in a more effective fashion.
Very interesting. So I like that idea that there was a medication to shrink the prostate. Is that something that you have to continually take? So there's really no permanent fix of shrinking it. It is just what it is.
Very well said. So all of these medications that we talk about are basically putting a Band-Aid on an open wound. They will temporize the problem, but they will not permanently fix it. And unfortunately, patients will be on maximum medical therapy and still have these symptoms because the body has adapted to the medications. And that's when we begin to discuss certain procedures in our office that we can offer patients that will completely take them off their medications and buy them 5 or 10 years without having to worry about this kind of issue. We're spending a lot of time discussing with our patients minimally invasive techniques that are done in our office under local anesthesia, and patients go home right after the procedure and they're able to pee much better without the use or the need of medications, one of which is something called a Resume. I believe at this point we're basically the only office offering actually Resume or water vapor therapy, where we are injecting the prostate gland at 9 seconds in injection with sterile water. The sterile water becomes steam, and the steam creates a thermodynamic reaction within the prostate gland, and it basically dissolves the prostatic tissue through time. My patients have been extremely pleased with this because of how minimally invasive it is, and we're able to take these patients off their medications at the 3-month mark, and there's essentially no sexual side effects whatsoever.
Very interesting. Let's tie these two topics together. Is there any risk once you have an enlarged prostate or you're dealing with that situation? Is there any risk of then developing prostate cancer from having an enlarged prostate?
So having an enlarged prostate does not increase the risk of developing prostate cancer. Okay. However, what differentiates the prostate cancer modalities and the BPH modalities is that, and when a patient comes into our office having these symptoms, we do check a PSA, but we don't necessarily think that because a patient has an enlarged prostate that they have an increased risk of developing a prostate cancer, because there are patients with the normal walnut size of a prostate gland is around 30 grams or so. We have patients who come in with 100-gram prostate, elevated PSAs, but there's no evidence of any cancer inside of the prostate gland.
So there's no connection necessarily. One does not necessarily lead to the other.
Exactly.
Okay. All right. So let's talk about some of the treatments let's go back a little bit to prostate cancer and talk about some of the treatments and the surgery. And you had been mentioning some of the side effects that are still possible. So let's say that you are that unfortunate man who has the high risk prostate, and can we talk about the surgical techniques that are used and what are some of the side effects and
Right.
yeah.
So in patients who have been diagnosed with high risk prostate cancer, the options are the following. A radical prostatectomy, which is basically the complete removal and resection of the prostate gland along with the seminal vesicles. As a result of that, we have to reconnect the bladder and the urethra. When we reconnect the bladder and the urethra, we're removing the prostate gland and allowing the plumbing system to function as it normally would. After patients go through a radical prostatectomy, there are two major things that they have to keep in mind. Their erections may not be the same, okay? And the risk of incontinence is also something that's very real. Now, patients may have issues with the idea of having to wear diapers or depends after a prostate surgery, but it is certainly a possibility. Now, given the expertise of the urological oncologist that's performing the surgery, the risks of having those issues goes down way less. However, even in the hands of the most gifted surgeon, there is still a risk of developing erectile dysfunction and urinary incontinence because of the amount of nerves that surround the prostate gland are directly responsible for erections and the sphincter mechanisms that control urination. So those are two major things that patients have to keep in mind. Most of these surgeries, patients will spend about a night in the hospital and go home the next day with a catheter in place, and they'll return to the office a couple weeks later for the catheter removal.
So what I'm hearing is it's better to get this diagnosed early and not end up in that late stage or that high risk time.
Absolutely.
And I had been under this, or I think it's probably a misapprehension that with surgery that those risks of incontinence and sexual dysfunction were less than they used to be. But I guess the surgery, as developed as the surgery has become, it's probably not. It's still not great.
It's not. Yeah. I wouldn't say that it's not great. I would just say it's not perfect. Okay, there is still a risk.
It's better.
It has significantly improved. Absolutely.
Okay.
It has significantly improved. There's no doubt about that. But again, these are discussions that you have to have with your patient. And if the patient tells you, look, my erections are extremely important to me, the idea of me having to wear Depends or diapers after the surgery scares the heck out of me, doc, then that patient may benefit quality of life more from radiation. When we look at the studies that compare the outcomes and the cancer control mechanism between surgery and radiation, we know that at the 10-year mark, the outcomes are exactly the same. Wow. Oncologically. So oncological control is basically the same at the 10-year mark as per the studies. What is not equivalent is the rate of erectile dysfunction.
Okay, so it's an interesting conversation for a patient to have with their doctors, their team of doctors at that point, if they're facing that kind of a diagnosis. Right. Okay, so let's talk, and I think that we'll close our webinar with lifestyle discussions. So other than ethnicity and genetic predisposition and age, are there things that our community members can do that actually helps prevent the onset or keeps these things? I mean, we're talking exercise, diet, what have you. Are these things effective in any way to keeping people healthy, even their prostates?
Without a doubt. Without a doubt.
Okay.
As you eloquently pointed out, diet and exercise are a huge component of some of the things that patients may experience as a result of them unfortunately having bladder irritants, too much bladder irritants in their diet, such as too much coffee or caffeine or carbonated beverages or spicy foods. Having patients exercise daily has been shown and proven to reduce the risk of developing these BPH symptoms. And that's super important to make sure that we discuss with our patients, making sure that diabetes, which is a huge component for why men and women may suffer changes in the way that they urinate, because the nerves of the bladder become sort of insensitive to the need to urinate as a result of diabetes and blood glucose levels not being in full control.
That's very interesting. So you mentioned a couple of things about diet. Spicy foods is not necessarily on like a cardiovascular diet, or are there sources and resources that you make available that you know about for your patients when they're looking to improve outcomes for, even if it's BPH or for prostate cancer? Are there special diets? Are there sources of information?
Absolutely, there are. We have tons of information in our office that can be easily accessed to our patients, even on our website at Advanced Urology Centers of New York. They can go onto the website and pick and choose the issues that they're having and what can promote the decreased risk of developing these symptoms from BPH or even prostate cancer. The huge components that we discuss are the same things that affect diabetes, the same things that sort of affect cardiovascular health will have a negative impact on the prostate gland and erections and the prostate itself when it comes to enlargement. So I would have patients really focus on ensuring that diabetes is well controlled, that they're eating accordingly, and not having too many carbohydrates, staying away from very sugary foods, of course, and the bladder irritants. Patients who are drinking 3-4 cans of soda have to be careful because their bladder will not be happy about that.
Okay.
And the spicy foods have been proven to have been shown to increase the risk of developing cystitis, which is bladder irritation. Bladder irritation leads to prostate inflammation, and that leads to the signs and symptoms of BPH.
You know, it's funny, we didn't actually talk about prostatitis. Prostatitis, is that how you say it? And can we just talk a little bit about that and understand what causes that?
So prostatitis comes in two forms. The first is an acute form, which is unfortunately very painful for patients, and the other form is chronic. Patients who have acute prostatitis will have fevers, signs of infection, difficulty urinating, blood in the urine, pain with urination. Patients who are drivers, taxi drivers or bus drivers, or that work in construction or on those big heavy machines, those patients have a constant pressure on their prostate gland, especially with all those bumps in the roads, for instance. A lot of those patients who are in their 30s and 40s will come to our office with complaints of BPH, but they're so young, and you ask them, has anybody in your family had these issues before? And they tell you no. It's most likely that these patients are suffering from a form of prostatitis, where there's an overall inflammatory issue with the prostate gland as a result of what they do for a living. And what that comes back down to is keeping it simple, making sure that the bladder is consistently and adequately emptied throughout the day. We discuss our rule of twos with the bladder training, and we make sure that these patients, if they do have an infection, that we treat their infection, and sometimes it may require 3 to 4 weeks of antibiotic therapy.
That's really interesting. So that's acute and chronic. What's the deal with chronic prostatitis?
So with chronic prostatitis, it really mimics and coincides with the symptoms of having an enlarged prostate. In a man who's 40 or 45 years old, chronic prostatitis will appear with patients waking up very often to go to the restroom. They'll feel as though that there's a constant pressure in their perineal area, where they feel like they're almost being kicked down there, and that's literally how they'll describe it. And that's sort of a telltale sign that there's something wrong with the prostate gland, in that the cells within the prostate gland are becoming inflamed on a daily basis.
So there are things to be done for that. There are ways to deal with it. Yes,
there are ways to deal with it, and it really, I harp on this with my patients, but it's shown to be, it's proven that it will assist patients in prostate in prostatitis, and just ensuring that their bladder is adequately emptied, using those rule of twos, going often, spending a little more time with moving your feet after you're done urinating and voiding one more time or double voiding, and less fluids prior to bedtime.
Okay. Well, that's it for my questions. Do you have anything else that you want to add for your talk? I think you covered a lot.
Yeah, just one point. I think When it comes down to BPH symptoms and men who are suffering from waking up, 2 to 3 times at night, feeling as though they're spending a little more time in front of that toilet, the longer you wait, the less likely it is that we can offer you a minimally invasive procedure. Because once the prostate gland gets to a certain point and the bladder is affected by that, okay, we have to become a little more invasive with our techniques to reduce the prostate size. So all my men out there, just watch these symptoms, and if you do have these symptoms, please talk to your primary care physician and discuss whether or not a urology consultation is warranted.
So again, I think we should end on the idea that everyone needs to go to the doctor, see their primary care physician every year, have these discussions, and when warranted, make a visit to see Dr. Fakhoury. So thank you so much, Dr. Fakhoury. I think we are good. We do have a couple of announcements. For anyone in our audience who would like to connect with Dr. Fakhoury, he is at Advanced Urology Centers of New York, which is across the street from our Andrews Pavilion of St. John's. That's 944 North Broadway. His number is there at 968-0000. If you need information about Dr. Fakhoury and you don't remember this phone number, feel free to email us at info@riversidehealth.org. And then the next slide is on virtual urgent care. We still have COVID and flu and RSV in our communities. So if you do have a discomfort, but you do have symptoms and you don't want to come into a doctor's office, feel free to call for virtual urgent care to determine whether or not it's something you really need to check out. 914-207-0006, and we can help you through virtual urgent care. And finally, if you have questions, info@riversidehealth.org comes to me. Physician referral, find a doc at riversidehealth.org. We do have 2 phone numbers for physician referral. One's for English, one is for Spanish. For English, it's 964-4DOC, and for Spanish, it's 964-4245. So, and those are both 914 numbers, obviously. Again, I want to thank Dr. Fakhoury and all of our attendees today for being with us. Join us again. We'll be back in the new year with a lot more.